Every human being you have ever met arrived through a process that, until very recently, involved no hospital, no epidural, no sterile gloves, and absolutely no cheerful machine going beep. Kings were born this way. Farmers were born this way. The person who invented taxes was also born this way, which feels like a missed opportunity. For most of human history, childbirth happened at home, in huts, tents, courtyards, caves, and crowded rooms filled with relatives who had strong opinions and no medical degree. Yet humanity survived. More than survived, actually. We multiplied with the determination of a species that had not yet discovered streaming services. So how did ancient women give birth without surgeons, antibiotics, blood transfusions, or emergency rooms? Who helped them? What did they know? And what happened when something went wrong? The answer begins long before the first birthing chair, before written medicine, and possibly before Homo sapiens. Because human childbirth was never meant to be a solo performance. To understand why ancient women needed help giving birth, we first have to address an uncomfortable question. Why is human childbirth so difficult in the first place? Most mammals make the whole process look suspiciously manageable. A deer gives birth in a field, cleans the newborn, and within hours the baby is attempting to walk. A human baby arrives unable to hold up its own head and immediately demands several years of full-time customer support. Our difficulty begins with two evolutionary developments that were individually brilliant and collectively inconvenient. First, our ancestors began walking on two legs. Bipedalism freed the hands for carrying food, making tools, holding infants, and eventually gesturing aggressively during arguments. But upright walking also reshaped the pelvis. The human birth canal is not a simple, straight tunnel. Its dimensions change from top to bottom, meaning that a baby usually has to rotate during labor to pass through it. Then human brains became larger. A newborn's head is enormous relative to the space available. The shoulders also have to navigate the pelvis, creating a complicated sequence of turns that resembles someone trying to move a sofa through a narrow staircase, except the sofa is alive and everyone is screaming. For a long time, scientists described this problem using the obstetrical dilemma. The traditional idea was that evolution had to compromise between a pelvis narrow enough for efficient walking and one wide enough for giving birth to large-brained babies. That explanation is useful, but modern researchers consider it incomplete. Pelvic shape varies significantly among individuals and populations. Wider hips do not automatically make walking inefficient, and childbirth is influenced by much more than bone width alone. The mother's body size, the baby's position, nutrition, hormones, soft tissues, activity, and even local environmental adaptations can all affect the process. Evolution, as usual, did not produce one elegant solution. It produced a collection of compromises held together by biology and optimism. Human babies also enter the world unusually helpless. Compared with other primates, much of our brain growth continues after birth. This may partly prevent the fetal head from becoming even more difficult to deliver, although scientists still debate exactly why human pregnancy ends when it does. One hypothesis emphasizes the physical limits of the pelvis. Another focuses on the increasing metabolic cost of supporting a rapidly growing fetus. The likely answer involves several pressures rather than one dramatic evolutionary deadline. What is clear is that birth became a uniquely demanding event. Human infants often emerge facing away from the mother, making it difficult for her to guide the baby safely, clear the airway, or manage the umbilical cord alone. That changed childbirth from a private biological act into a social problem. And humans are extremely good at solving social problems by assigning the job to someone's experienced aunt. Once childbirth became too complicated to handle reliably alone, the obvious human solution was cooperation. We do this constantly. One person hunts, one person gathers. One person remembers which berries cause visions and which berries cause funerals. Knowledge gets distributed across the group, and survival improves. Birth assistance may be one of the oldest examples of that strategy. Among most non-human primates, females usually give birth alone. Humans are different. Across cultures, childbirth is commonly attended by other people, especially experienced women. Anthropologists have argued that this pattern may be ancient because the mechanics of human birth make assistance unusually valuable. A laboring woman could move, squat, kneel, lean forward, or brace herself against another person. Someone else could massage her back, support her weight, offer water, watch the baby's position, remove membranes from the newborn's face, manage the umbilical cord, and respond if the mother became exhausted. None of this required a hospital. It required attention. The first birth attendants were probably not formal medical professionals. They were mothers, grandmothers, sisters, aunts, neighbors, and women who had seen enough births to recognize when things were progressing normally and when the room was about to become very quiet. Their knowledge would have been practical and cumulative. Which positions helped labor move forward? Which kinds of bleeding were expected? How long could labor continue before danger increased? When should the mother eat, rest, walk, or push? What could be done when the baby appeared stuck? Answers were learned through experience, observation, memory, and tragedy. That last part matters. Ancient birth knowledge was not created in a peaceful laboratory. It was built through generations of women watching what worked, what failed, and what they never wanted to see happen again. This also helps explain why childbirth became surrounded by ritual. Practical care and spiritual protection were not separate categories in the ancient mind. A birth attendant might adjust the mother-S position while another woman recited a prayer or placed an amulet nearby. One action addressed the body. The other addressed fear, uncertainty, and the invisible forces everyone assumed were involved. Honestly, when no one understands bacteria, blood pressure, or fetal distress, an angry spirit did it is at least a theory. But support itself had real value. Familiar voices could reduce panic. Touch could provide comfort. Upright movement could help labor. Experienced attendants could recognize obvious emergencies even when they had few tools to solve them. Birth was therefore not simply a woman fighting biology alone. It was a group surrounding one vulnerable person with every scrap of knowledge the community possessed. The earliest delivery room was not a room at all. It was other people. The problem with studying ancient childbirth is that it rarely leaves behind the kind of evidence archaeologists enjoy. No one buries a neatly labeled box marked "Emergency Delivery Equipment 2400 BC." Most births happened in ordinary homes using perishable materials: cloth, wood, rope, plants, hands. Especially hands. These things decay, disappear, or get mistaken for something less dramatic, so researchers have to work with fragments. One of the most fascinating comes from ancient Egypt, a decorated mud brick discovered at Abydos in a building associated with a wealthy household from the Middle Kingdom, roughly 700 years ago. The brick shows a mother holding a newborn while surrounded by female figures connected with birth and protection. Scholars believe it may have been one of the bricks women used during delivery. Instead of lying flat, an Egyptian woman could squat or kneel with her feet raised on two bricks, creating space beneath her body while attendants supported her. Gravity helped. The pelvis could move more freely. And nobody had yet decided that childbirth should resemble a patient waiting for a dental cleaning. Ancient Egyptian texts also refer to women giving birth upon bricks, while religious imagery connected the process with goddesses such as Hathor and protective beings associated with pregnancy and infancy. The objects were practical, symbolic, and possibly magical all at once, because ancient medicine loved multitasking. Evidence becomes clearer in the Greek and Roman worlds. Around the 2nd century A.D., the physician Cyrannus of Ephesus wrote one of antiquity's most detailed surviving accounts of childbirth and midwifery. He described the qualities of a capable midwife, methods for examining labor, ways to support the mother, and the use of a birthing chair. The chair had a seat with an opening in the center. The laboring woman sat upright while attendants stood beside or behind her, and the midwife worked in front. It looked less like a modern hospital bed and more like furniture designed by someone who understood gravity, but had become personally offended by comfort. Women also gave birth while squatting, kneeling, standing, or leaning against another person. The exact position depended on local tradition, the stage of labor, the mother-S strength, and whatever seemed to be working. This flexibility is important because the standard flat on the back position common in later European hospitals was not the universal human norm. Upright and mobile birth positions appear repeatedly in historical art, medical writing, and cross-cultural observation. None of this means ancient childbirth was safe. A brick could not stop a hemorrhage. A chair could not correct every obstructed labor. An experienced midwife could recognize disaster without possessing the surgery, antibiotics, or blood supply needed to defeat it. But the evidence destroys the idea that ancient women simply wandered behind a hut and hoped for the best. They had techniques. They had specialists. They had equipment. The maternity ward was smaller. The stakes were not. Ancient childbirth care occupied a strange territory between medicine tradition, religion, and educated panic. Some techniques were practical. Attendants used massage, warm water, oil, movement, pressure, food, rest, and changes in position. They watched the mother-S breathing, the timing of contractions, the appearance of the baby. and the amount of blood. Even without modern anatomy, repeated experience could reveal patterns. Certain remedies may also have had real effects. Heat can ease pain. Hydration matters. Physical support reduces exhaustion. Some plants contain compounds that influence uterine contractions, inflammation, or alertness. The difficulty is that ancient healers did not know which effect came from chemistry, which came from comfort, and which came from the fact that the mother was going to recover anyway. That is how medicine develops a very awkward roommate. Magic. Women wore amulets, invoked deities, recited protective spells, burned incense, tied knots, untied knots, and placed symbolic objects around the birth space. In several cultures, difficult labor was imagined as a blockage that could be opened through ritual. Doors were opened. Hair was loosened, belts were removed, knots were undone. The symbolism was not subtle, but it was psychologically powerful. Ritual gave people something to do when they had very little control. It organized fear. It reassured the mother that the community, the ancestors, and possibly several highly specialized gods were all working the night shift. The problem came when confidence exceeded knowledge. Ancient medical texts contain remedies that sound reasonable, remedies that sound harmless, and remedies that sound like someone lost a bet. Substances could be swallowed, burned, rubbed onto the body, inserted vaginally, or combined into mixtures based on resemblance, tradition, or spiritual association. Some ingredients may have relieved symptoms. Others were ineffective. A few were toxic. And because ancient writers often recorded treatments without reporting success rates, we cannot assume that a remedy worked simply because someone wrote it down. People write down terrible ideas all the time. We have social media now. There were also severe complications that no prayer, herb, or experienced hand could reliably solve. A baby positioned sideways, a pelvis too narrow for delivery, a retained placenta, uncontrolled bleeding, seizures, or infection could turn an ordinary labor into a fatal emergency. Midwives sometimes attempted repositioning or manual extraction. Physicians might be summoned in elite households. Surgical tools existed, but major intervention was extremely dangerous, and cesarean delivery was generally not a realistic rescue procedure for a living mother in most ancient settings. This is where the evidence demands humility. We know ancient attendants possessed genuine skill. We also know their explanations mixed observation with belief. What we cannot know is how many undocumented techniques existed, how consistently they worked, or how much expertise varied between communities. Ancient childbirth was not primitive ignorance. It was intelligent people working with incomplete information, which uncomfortably describes much of human history. Once childbirth knowledge became valuable, the people who carried that knowledge became valuable too. Midwives were not simply women who happened to be nearby. In many societies, they developed specialized reputations, practical authority, and a kind of social power that did not always appear in official records. A skilled birth attendant might know which positions eased labor, how to encourage breathing, how to recognize a dangerous presentation, how to care for a newborn, and when a mother was beginning to fade. That made her part healer, part counselor, part emergency manager, and part keeper of secrets. Birth involved far more than producing a baby. It established family lines, inheritance, citizenship, legitimacy, and social status. The identity of the mother mattered. The identity of the father mattered. The timing mattered. The witnesses mattered. Ancient society could turn a newborn's first breath into paperwork before paperwork even existed. In elite households, childbirth could become a political event. A successful delivery might secure a dynasty. A failed one could trigger remarriage, succession disputes, or accusations that someone had offended a god with suspiciously specific interests in royal genealogy. Among ordinary families, the stakes were just as real. A child added labor, continuity, and future security, but pregnancy and birth also placed the mother at enormous risk. Communities therefore built customs around the event. Women gathered together. Men were often excluded from the immediate birth space. Food was prepared. Protective objects were arranged. Certain words were spoken, and certain actions were avoided. These rituals did not merely reflect superstition. They transformed a terrifying biological event into a shared social process. The mother was not alone. She belonged to a network of women who had endured the same pain, witnessed the same dangers, and inherited techniques from people who were no longer alive. Every birth became both a medical event and a transfer of cultural memory. Midwives also shaped the first moments after delivery. They might clear the infant's mouth, tie or cut the umbilical cord, wash the baby, examine its body, stimulate breathing, and decide whether it appeared strong enough to survive. That final judgment could carry disturbing power. In societies where severe disability, poverty, or questions of legitimacy threatened the household, the reception of a newborn was not always automatic or compassionate by modern standards. Birth created a person biologically. Society still had to accept them. Over time, states, religious authorities, and male physicians increasingly tried to regulate childbirth. But for most families, the essential knowledge remained in the hands of women who had learned through apprenticeship, observation, and repetition. They preserved humanity with no formal hospital, no standardized license, and no malpractice insurance. Just memory and steady hands. Ancient women gave birth before hospitals because there was no alternative. They relied on experience, community, movement, ritual, and courage. Sometimes that was enough, sometimes it was not. The most dangerous complications of childbirth are often brutally simple. Too much bleeding. A baby that cannot pass through the pelvis. Infection entering damaged tissue. Blood pressure rising until the mother begins to seize. A placenta that will not detach. A newborn that does not breathe. Ancient attendants could recognize many of these disasters, but recognition is not the same as rescue. This is the part of the story nostalgia tends to edit out. Natural birth was not automatically peaceful, empowering, or safe. It was natural in the same sense that storms are natural. Most passed, some destroyed everything. Modern hospitals changed childbirth not because women had forgotten how to give birth, but because medicine finally developed tools for the moments when the body's ordinary process failed. Sterile technique reduced infection. Blood transfusions made catastrophic bleeding survivable. Antibiotics fought bacteria. Caesarean surgery turned some obstructed labors from death sentences into emergencies with solutions. Drugs could control seizures, strengthen weak contractions, or reduce dangerous bleeding after delivery. None of these advances made birth effortless. They changed the odds. And yet, in a modern delivery room filled with monitors, specialists, surgical equipment, and fluorescent lighting, something ancient is still happening. A laboring woman still looks for a familiar voice. She still reaches for a hand. Someone still tells her when to breathe, when to rest, and when she is stronger than she feels. That part predates hospitals. It may predate cities, writing, agriculture, and every religion whose gods were later asked to protect the birth room. Human childbirth became survivable not through biology alone, but through cooperation. Our ancestors met one of evolution's most dangerous challenges by refusing to face it alone. That is the real inheritance of the ancient midwife. Not a specific herb, not a magical brick, not a birthing chair designed with open hostility toward upholstery. Presence. Every person alive is descended from an uninterrupted chain of successful births stretching back beyond our species. Behind that chain were millions of women, and beside many of them stood someone else, holding their weight, watching the blood, receiving the child, and hoping both would survive. The first delivery room was a community. The modern one still is, it just has more beeping.